Hello, everyone. Welcome back. My name is Tina Costa, and I'm one of the directors with the Office of Virtual Health here at PHSA, continuing to be your host for these virtual sessions. It's my pleasure, again, to welcome you or re-welcome you to day two, afternoon of day two in the 2023 BC Digital Health Forum. For those of you joining our virtual circle this afternoon, encourage you to share in our collective gratitude for the opportunity to come together from many traditional, ancestral, and unceded territories of BC First Nations as we continue to engage, to learn, and to collaborate in the realm of digital health. Let us give thanks for the privilege to do so on these beautiful lands and sacred spaces. May our discussions contribute to a future where Indigenous voices are uplifted and the principles of reconciliation guide our path forward. It is now my pleasure to introduce our next presenter, Dr. Elizabeth Keys. Dr. Keys is a registered nurse and assistant professor in the School of Nursing, Faculty of Health and Social Development at the UBC Okanagan campus, with a clinical background in school, community, and public health nursing. She also holds adjunct positions in the School of Nursing at Dalhousie University and the Faculty of Nursing at University of Calgary. Prior to joining the School of Nursing at UBCO, Dr. Keys completed an interdisciplinary CIHR funded postdoctoral fellowship at Dalhousie University in the Department of Psychology and Neuroscience. Dr. Keys obtained her PhD and RN from the Faculty of Nursing at the University of Calgary. My pleasure to hand things over to yourself, Dr. Keys, on your talk entitled here, Structured Data Collection Through Virtual Health in Sleep Assessments.
Hey, wonderful. Thank you so much for that introduction. I'm so pleased to be presenting on behalf of our team today. My background is in nursing and community health, and so one of the things I really love about this project is the potential to kind of integrate community health services with hospital-based services, and see where we can go from that. Because my main purpose is helping families receive appropriate supports for their sleep health. So thank you for that lovely acknowledgement at the start. I'd also like to acknowledge that I'm coming from today the Okanagan, which is located in the traditional ancestral and unceded territory of the Syilx Okanagan people. And here's a beautiful image. We're a few months away from the sign of the first spring in the Okanagan, but I just really love sharing this image because I'm grateful to the First Nations who've nurtured and cared for the lands and waters around us and allow for these beautiful things to flourish. I'd also like to acknowledge, though, myself as a white settler who's benefited from living and working in a system, multiple systems that have done harm to Indigenous people, and the ongoing work that myself and colleagues need to do. One of the things that I'm doing and considering to and continuing to do is considering how learning about the truths and the In Plain Sight report is really a good space for that. And one thing that I think is really relevant from that informs my way of thinking about this particular research project is that Indigenous respondents in one of the surveys that was included in and spoken about in this report that they are 7 times more likely than non-Indigenous respondents to report that staff always treat them as if they're bad parents. And so working in a pediatric focused healthcare system, I think this is something that we really need to think about throughout this work. Sleep is a huge part of my program of research, so I'm pretty biased, but there is growing acceptance and awareness that sleep is the foundation of health, much like diet and exercise, and that there are really important reciprocal relationships between sleep and different domains of health, including exercise, pain, stress, anxiety, and other mental health issues. And this growing awareness is leading to an increased need for sleep services, including in the pediatric domain. And when we think about children's sleep in Canada, we have a couple of kind of important things to consider. So there are national guidelines on sleep duration for how much sleep children and adolescents should be getting, and about 3/4 to 2/3 of children and adolescents are meeting those guidelines. And then we can also think about how the pandemic kind of shifted or either caused problems to worsen or potentially improve, but it definitely had an impact either for the better or for the worse of sleep for children and youth. So sometimes when they had structures and routines kind of lifted, or there weren't so many activities going on, their sleep might have improved, but for a significant portion of children or adolescents, their sleep may have worsened. And so kind of this growing awareness on top of kind of the current and expanding mental health, a growing increase in mental health concerns is leading to increased need for pediatric sleep services in Canada. And so, as I mentioned, that's partly due to recognition of sleep as being important for health, not only from the public, but also from other care providers. So sometimes there's growing recommendations that children or adolescents with certain medical conditions or experiences also get sleep screening. So for instance, children with ADHD, it's recommended that they get sleep screening, and children with Down syndromes, a recommendation is that they should have a sleep assessment before 4 years of age. So that's leading to demand for services that's often greater than the capacity, even though sleep labs and clinics are trying very much to increase their capacity. The need is continues to outgrow that. Also in combination with the fact that services are not universally accessible across Canada, so they're often tied to urban centers that are joint with a major academic center. And on the map here, you can see that there's no major center past or east of Montreal. So that's leading to a discrepancy in terms of accessibility. And then lastly, the tiers of service are not well integrated. So people in the community often don't have a lot of training or expertise in how to screen for and address sleep problems. And so that may be also contributing to kind of increased referrals in terms of, not knowing how to manage these cases in the community or support families. And then either not addressing them or referring them on to more specialized services. At a recent symposium that our team led at the Canadian Sleep Society meeting earlier this year, many colleagues shared similar concerns about, resources, accessibility, time, wait lists, as being a big problem in delivering pediatric sleep problems. And so, as I mentioned before, it's no surprise that as the wait lists that wait lists have continued to grow, and so that's really the key reason why we're doing this work. And so our team wanted to know, how can a structured intake and screening process help reduce those wait lists and be responsive to that, because we do believe like children and adolescents should have access to sleep services and appropriate sleep services. And so to tackle this problem, we kind of approached it two ways. One was, how can we use digital or virtual kind of components to help improve this. And then the second piece is more people-based in terms of interdisciplinary perspectives, and using those interdisciplinary perspectives to tackle this problem. And so our team put forward an application to look at the barriers, facilitators, and outcomes of clinical kind of system, digital clinical system to improve pediatric sleep care pathways, and was successful with the UBC Health Award. However, this work started over a decade ago with Dr. Osman Ipsaroglu kind of coming up and leading a group in thinking about how we can develop educational and communication strategies that is aligned with the tiers of service. So service in the community up until child health focused, and then more specialist child health focused ones, and how we can talk to each other and create a shared understanding and approach, and think about, you know, what kind of screening can be done in the community, and then triage, like increasing triage as the levels go up. And so from that, a quality improvement initiative was started looking at implementing that model and articulating that model in terms of how people can, or clinicians can, take that information from a screening and think about not just the sleep specific factors, but also the underlying root causes, kind of what that's looking like functionally for people in their real lives, and any other conditions that might also be related to sleep issues, and then thinking about medication-based interventions and non-medication-based interventions. And so that's the model that was developed and tested for feasibility in a response to deal with that wait list. And then so what this looks like is a referral to the BC Children's Sleep Clinic, Sleep Wake Behavior Clinic. The patient or the parent more often fills out the online intake form that includes both open-ended responses that are goals and concerns of the patient or family. This is in addition to the referral letter from the referring provider. It also asks people to fill out validated tools like the sleep disturbance scale for children that can be kind of used for a broad range of sleep difficulties. And there are some other quantitative kind of questionnaires also included. It asks people to report on medications and supplements that they're using or have used, and then a little bit of medical or family history. And so then the clinician can take that information, review the intake form according to that model or framework, conduct a screening phone call if there's clarifications that need to be made, or to find out a little bit more information, and then develop an action or triage plan. Where people who need to urgently get seen urgently. People who probably do need in-person contact or telehealth appointment are booked for that, but also that maybe there's some other things that they can try in the meantime, or other assessments that they might need to get, so that ends up streamlining their appointment. And then green might be follow-up in the community, so recommendations are made back to the referring provider about some community-based strategies that could be implemented first before referring on to the sleep wake clinic. So what we wanted to tackle with our project, so that was all the pre-work that was done, and we wanted to look at how can we expand this e-health intake and triage and screening pathway for British Columbia. So we thought about 3 different things that we wanted to do to answer that question. One was to conduct an environmental scan of Canadian pediatric sleep clinics and labs. The second was to integrate interdisciplinary perspectives, both in terms of the training and who could be doing that triage work, and then also in terms of the data management and the data system. And then the third is to understand the impact of the structured intake screening and triage pathways. So we have a mixed method study to compare both the sleep parent-reported sleep outcomes, and then parent perceptions about the quality of care. So first I'll speak about the environmental scan that we did, and no surprise to us, but you know, it was validating that 90% of other centers had a wait list. So that's a big kind of piece that it's not just an us problem, it's an everywhere problem. For the sleep scan or environmental scan, we did a purposive sample of all the major academic and health center services that were known to provide pediatric sleep services. It's a small pool. So we feel we got 13 full and four partial responses that covered almost all the known Canadian pediatric sleep services, both the labs, so the polysomnography labs, and the clinics. And 90% were affiliated with an academic or health service center. And what was interesting is most clinics and labs used a structured referral or intake process. There was a range of professionals who completed that intake and triage process. So it ranged from sleep physician specialists to registered nurses or respirology nurse, nurse practitioners, LPNs, and then more non-specific kind of responses about a clinician or team lead. And then in terms of what that intake and triage process was looking at, some people did report using electronic intake form or using a set referral form and criteria or validated questionnaires. Some people reported no structural tools, and then others said that they just use kind of clinical knowledge and prioritization. So really demonstrating a wide breadth of ways to actually operationalize those intake and structure and triage processes. And the last thing we wanted to know related to this project is who is part of their team, just to see the different kind of models that might be out there. And so there's a wide range of different disciplines represented on the sleep clinics and labs throughout the country. And the ones with asterisks are the ones that are only involved in the sleep clinics, not the labs. So, but there is quite a lot of overlap in interdisciplines working together. So our main takeaways from this is that waitlists are a national problem in pediatric sleep services, not just a us problem. Their structured intake process is very common, but variable in terms of operationalizing it. And there's a wide range of interdisciplinary teams. So then the next part that we wanted to think about was how can we integrate these interdisciplinary perspectives into both the training process for this kind of intake screening and triage pathway, and then also in terms of the data. And the first thing that we found out very quickly was that we needed to develop a shared language and understanding with each other. And so we conducted a series of interdisciplinary meetings and kind of case studies to understand the process and the potential for expanding not only the process to include other disciplines beyond physicians and medicine, but also different medical specialties. So, you know, this was focused mainly on the sleep-wake behaviors, but maybe this could extend to more respiratory-based sleep problems. And then engineering also in terms of trying to understand how we could maximize the data management processes. So one example of it, one of the outputs from this is the creation of standard operating procedures, where we take all that knowledge that's captured inside specialist's head and try to map it out in terms of what the processes are. Another thing that we did was develop a half-day crash course kind of outline or process that included a praxis component and a manual that people could refer to. And we were able to feasibly do this, but it might need to be tailored differently for different audiences or kind of in terms of sustainability. And one of the things in terms of sustainability that we found out was that we maybe needed a little bit more of introductory kind of learning module that could be done by different disciplines to really learn that shared language. So one of the things that is currently in development is an e-learning or asynchronous learning module, which walks people through different case studies and how to use that model in the triage and the assessment and developing recommendations. So there's different case studies and then kind of interactive yes, no with explanatory bits about guiding them through the thinking about that process. The other thing that we did in collaboration with Dr. Calvin Koo at UBC Vancouver Faculty of Engineering is work with a engineering capstone team to create a data visualization tool. So they created this application for the computer where it allows clinicians and learners to explore potential like real trends in the clinical data set. So it talks to the REDCap platform, or it can talk to an output of the REDCap platform, and it can basically help people understand the different relations between the different components of that logic model or that framework for the screening and the assessment. So for instance, you can pick people who are on stimulant medications, and then it lets you put that in and filter it, and then it's color coded in terms of the strengths of the correlations between other kind of diagnoses or other medications, so that can help people see the interrelations between different variables, and you can even go more specifically into it to see how strongly correlated things are. And as the clinical database grows, we can, this was a proof of concept, but we can build on this to then monitor trends in a real-time way that will help identify kind of emerging trends in the clinic's population. And finally, one of the big things we want to make sure is that we understand the impact of the structured intake, screening, and triage pathway in terms of patients and families. And so we've created a mixed method study that we'll imminently start data collection for. And it's the quantitative component is a quasi-experimental comparison of patient-reported outcomes or parent-reported outcomes and experiences of the structured intake and screening pathway compared to the standard care group. And then a subset of those people will be invited to participate in qualitative interviews to explore further kind of parent experiences and perceptions of care. And so this is what it looks like in a visual kind of way. So 5 to 12 months post-contact, individuals who have provided permission to contact for future research and have completed the clinic's structured intake form. So they have that data, that pre-data, will be invited to participate by completing an outcome questionnaire, which includes the sleep disturbance scale and the health services quality questionnaire. The health services quality questionnaire is something that we've developed specifically for this study, and it uses aspects or domains of quality from the BC Patient Safety and Quality Council, and also a QI tool that was developed from BC Children's Mental Health Program. So people will be invited to complete the outcome questionnaire, and then we'll retroactively extract baseline data, and this will be able to help us understand pre and post changes, and then a subsample from each pathway will be invited to participate in interviews, and this will allow us to compare and contrast kind of patient experiences. And so in terms of anticipated results, our hypotheses is that children and youth in the structured intake and screening pathway will have perceived improvements in their sleep that are comparable to those receiving standard care. So as one of the first studies really evaluating the impact, we want to make sure that it's not worse, it's at least the same or better. And then for both pathways, we expect that parents will rate most quality domains similarly, but we think that the domains of accessibility and efficiency might be rated higher in the structured intake and screening pathway. And then in terms of the qualitative work, we think that parents might perceive the structured intake and screening pathway as more of a facilitator of reducing wait times and being able to provide appropriate care at the right time. But some parents might see a lack of in-person kind of contact or the need for additional support or getting potentially recommendations to the referring provider as not supporting high quality care. So in terms of next steps and future opportunities, we're going to complete the data collection to evaluate the impact. And then along with those findings will be used along with kind of other learnings that we've learned through the process to revise that structured intake and screening system based on feedback. And then also ongoing research. So for example, there's different ways that we're already expecting we can optimize our data input. So the response categories could be more discrete, and that will allow for better reporting on the other end. There might be additional questions, say, that are collected right now during the screening phone call that could be collected upfront that are much more important in that decision making for the triage process and could be collected upfront. And then also leveraging some opportunities for automation. So you know, generation of automatic reports and things that might be able to automatically do things that humans are doing right now, that, you know, that tracking and of case management could probably be streamlined through automation. Looking at different primary clinical concerns, including obstructive sleep apnea, making sure that the intake form is including things that are important for those concerns as well. And then expanding capacity to upload different types of data is something that we'll be investigating, including like videos of respiratory events during sleeping, or wearable information, or different monitoring devices that people could upload to the platform. And then perhaps also be analyzed directly and feed into that report that the clinician gets to make the decisions about the triage. And then finally, testing the interdisciplinary tools in terms of trying to figure out the best way for it to become scalable and sustainable, especially since we know many of our colleagues across the country are experiencing similar challenges. You know, how can we train a workforce that can sustainably be trained in this kind of approach? And so for that, thinking about making open educational resources. So there's lots of things. One of the challenges with talks like this is trying to figure out what to focus on. There's lots of people who, as I mentioned, this work was started over a decade ago. And so just some brief acknowledgements of some working groups and some staff and students that have helped out, as well as some funding. So I'd be happy to take some time for questions now if we still have time, or
thank you so much, Dr. Keys. A fantastic presentation yet again today, and just really highlights how some of those electronic tools can help those upstream processes. And so really appreciate not only highlighting the critical importance of sleep. I wish my mom had known that when I was a child, but just really looking forward to the more learning that you and your team is going to gain from this. The environmental scan and the clinical database that you have was really incredible. We unfortunately don't have time for questions, but again, just reach out to Dr. Keys directly for questions and connections if it's of interest to you. You'll see the evaluation poll up right now just to get some big feedback on today's session. And we're going to, as quickly as we can, shift over to the next session, which is entitled The AI Hype for Clinical Decision Support in Healthcare. Once again, thank you so much, Dr. Keys, and have a great day.